Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of the McTox Curriculum built for residents and fellows from PGY 1 to 5. This presentation was prepared by Dr. Bandar Ba, and this topic is about anticoagulants. By the end of this 10 minutes, learners will be able to understand the classification of anticoagulants, explain an approach to anticoagulant overdose, and discuss management of anticoagulant toxicity. Let's start with a case. An 82-year-old woman presents with progressive confusion and easy bruisability for a few days. Her home meds are aspirin, warfarin, Lasix, lisinopril, and atenolol. Her vital signs are heart rate 114, blood pressure 109/66, respiratory rate 26, oxygen saturation 94%, and temperature 37.8 degrees. Her INR is found to be 4.9. What could be the differential diagnosis? How will you work the patient up? And how will you manage her coagulopathy? Consider case 2. A 26-year-old female is diagnosed with an oral contraceptive-associated PE and started on heparin. The nurse calls you because she thinks that she's administered 5 times the ordered dose in error 40 minutes ago. So far, the patient remains asymptomatic. How will you approach this situation? Generally, anticoagulant toxicity may result from either overdose or, more likely, from drug interactions, especially in elderly patients with polypharmacy. The main clinical picture of such toxicity is, of course, bleeding. Depending on the affected organ, the presentation can be stroke, GI bleed, retroperitoneal bleed, or compartment syndrome. There are several classifications for anticoagulations. We'll focus on the one most relevant to toxicology, and here anticoagulants are divided into 2 main groups, oral agents and parenteral agents. Most complications are due to oral forms. Oral anticoagulants include warfarin, warfarin-like drugs, and the long-acting superwarfarin, which all inhibit vitamin K-dependent clotting factors. Vitamin K-dependent clotting factors are 2, 7, 9, and 10, as well as protein CNS. Therefore, vitamin K is considered a classical antidote for this category of drug. In addition to warfarin, there are new novel oral anticoagulant drugs that target either thrombin, like dabigatran, or target activated factor 10, such as rivaroxaban. Parenteral anticoagulants include heparin, low molecular weight heparins, such as enoxaparin, direct thrombin inhibitors, such as bivalirudin, and factor 10A inhibitors, like fondaparinux. Let's go back to our patient in case 1. She takes warfarin, has an INR of 4.9, and is confused. In order to be able to manage possible oral anticoagulant toxicity, it's important to know if there's any life-threatening bleeding. After that, we need to determine the current INR. If there is life-threatening bleeding, then immediate reversal of warfarin is indicated using prothrombin complex concentrate. If there is no life-threatening bleeding, then INR is reversed only if it's higher than 10, using 2.5 to 5 milligrams of oral vitamin K. In all cases, warfarin should be withheld for the duration of treatment. The activity of novel oral anticoagulants is not precisely measured or monitored using INR, and its reversal is not covered in this material due to time. Warfarin-associated life-threatening bleeding should be treated with prothrombin complex concentrate, or Octaplex, which contains a combination of clotting factors 2, 7, 9, and 10, as well as protein CNS. If this is not available, then 10 milligrams of IV vitamin K, in addition to fresh frozen plasma, should be considered. It should be noted that FFP requires a longer time to INR reversal and has a higher risk of transfusion-related acute lung injury. In the case of heparin, drug activity, and therefore risk of bleeding, is measured by PTT. Protamine sulfate can be administered as an antidote to reverse heparin toxicity, and works by binding to heparin or low molecular weight heparin and forming a stable complex, inactive as an anticoagulant. Protamine sulfate has an immediate onset of action once given intravenously. It does effectively reverse heparin, but it only partially reverses low molecular weight heparin toxicity. The dose of protamine depends on the heparin dose administered and the time since administration. If given immediately after heparin, the dose is 1 milligram for each 100 units of heparin received. If heparin was administered within an hour, the dose is 0.5 milligrams of protamine for every 100 units of heparin. And if it has been greater than 2 hours since heparin administration, the dose is 0.25 milligrams for every 100 units of heparin. There is a risk of anaphylactoid reaction with rapid infusion of protamine sulfate. If this occurs, it should be treated with H1 and H2 blockers, with or without epinephrine. The risk of anaphylactoid reaction may be reduced by slowing the infusion rate. Review questions. Question 1. What is the treatment for INR of 3.8 and upper GI bleeding? Question 2. A patient presents with warfarin toxicity, INR of 8.3, and intermittent epistaxis. What is the treatment? Question 3. A patient received 5,000 units of heparin in error 5 minutes ago. What is the dose of the antidote?